Good morning. Today we will having a case discussion on gastric outlet obstruction. We have kept this patient as a complication of peptic ulcer disease because we will have a separate case on CS stomach. So Mehul was supposed to present. Let us, Dr. Shuham Shawant to start presenting. Comes and he joins the class. So Shuham, you just start presenting the history and.
Yes, one.
And Professor Ujjwal Bhattacharya, who is the professor head of surgery at National Medical College, will be the teacher today. Yeah.
Good morning, teachers and all the seniors and my colleagues present here. Today's case discussion is on gastric outlet obstruction following peptic ulcer disease. Patient particulars: name Mr. X, age 40 years, gender male, occupation manual laborer, address Tollygunj. Chief complaints: pain abdomen for past 2 years, vomiting for past 5 months. Patient was apparently well 2 years ago. Patient started having occasional pain in the mid-upper abdomen, which was moderate intensity, dull, aching. Intensity of pain started increasing following prolonged periods of fasting, usually lasted few hours and relieved partially with food intake and antacids. It was associated with heartburn, sour taste in mouth. These symptoms usually lasted 2 to 3 months and subsided with medication use and recurred after every few months. There is no history of radiation of the pain. For the past 5 months, the patient started experiencing occasional copious vomiting following heavy meals. Vomiting occurred around 10 to 12 hours after food intake. It was projectile and non-bilious in nature and contained undigested food particles. No history of blood in vomitus. For past 1 month, patient experiences vomiting almost after every meal, around 2 to 3 times per day, 4 to 6 hours after food intake. He often experiences a ball rolling movement in the upper abdomen following food intake, which subsides after vomiting for the past 5 months. No history of jaundice, no history of blood in stool. Past history: no history of diabetes mellitus, hypertension, or any other comorbidities. No history of allergies or chronic medication use. History of occasional pain medications and antacid use was present. History of open appendectomy 15 years ago. No history of TB or contact with TB patients. Personal history: he is married for 10 years. He takes mixed diet. Appetite is preserved. Patient complains of constipation for the past 2 months. Frequency of micturition is reduced. Sleep habits were within normal limits. There is history of loss of weight, which he is not able to quantify. There is history of alcohol binge drinking occasionally for more than 15 years. 15 years. There is history of tobacco smoking, around 5 to 6 BDs per day for more than 10 years. Family history: no history of similar complaints in the family. His parents are alive and healthy. He lives with wife and 2 children who are healthy. Treatment history: he underwent an abdominal ultrasound and an upper GI endoscopy 2 weeks before admission. He has been taking oral medications regularly for the past 2 months to relieve pain in abdomen and acidity.
Okay, wait. Mehul has come, so we'll face the question on history. So go back to history of present illness. Yes. Now, what we can discuss few things on history of
Yes. So we have got the history of present illness. So can you explain can you give us the full history of vomiting in this case? Can you give the detailed history in relation to gastric outlet obstruction? Okay.
How the vomiting started, he said.
So the vomiting started 5 months ago. First the
Yes.
patient started experiencing occasional vomiting after heavy meals. Then
Yes.
afterwards the vomiting started occurring 10 to it generally occurred 10 to 12 hours after food intake. It was effortless vomiting. It was
Yes, it
non-bilious
is
in nature,
effortless, non-bilious.
and it's a
Yes, go on, go on.
Yes, it contains undigested food particles. There was no blood in the vomitus. And for the past 1 month, the patient is vomiting almost after every meal, around 2 to 3 times per day, 4 to 6 hours after the food intake, sir. He also was experiencing ball rolling movement in the upper abdomen following the intake, which subsided after vomiting for the past 5 months, sir.
So it is effortless, copious. Have you mentioned about the projectile vomiting?
Yes, sir. Yes, sir.
So it is also projectile. Does the patient suffer from any pre-vomiting sickness?
No, sir.
Do
No, sir. No, not in such.
usually patients with gastric outlet obstruction, when he starts vomiting, he usually does not suffer from any pre-vomiting sickness. Okay, what are the other conditions where you can get the similar history, effortless, without any pre-vomiting sickness? So this is one, gastric outlet obstruction. Okay.
Yes, sir. So along with the so this is probably, sir, this one is due to a peptic ulcer, sir, for in cases of carcinoma of
So
stomach,
this
sir.
is gastric outlet obstruction as a whole. Other conditions?
Yes. So
So that can also, yes.
in cases of, sir, trauma, sir, head trauma, sir, there is projectile vomiting, sir, sometimes.
Yes, yes. Head injury. Head injury is
injury.
another situation.
Yes, sir.
And acute gastric dilatation. Acute gastric dilatation, or it can be proximal small bowel obstruction as well. Okay. So that is the full history of vomiting. So it is non-bilious, does not contains old food materials, and does not contain blood here. Na? That is the history.
No, sir. Yes, sir. No blood in the vomitus.
Sure.
And
So
Mehul, you are finishing the history mainly with no history of jaundice, no history of blood in the stools.
Yes.
So it's a GI patient.
Yes, sir.
Patient having some abdominal pain. So try to complete. This is a patient who may have other disease. Maybe a CA colon causing obstruction. Maybe a carcinoma head of the pancreas causing outward obstruction. So all the other symptoms related to the abdominal disease should come here. You have taken the bowel habit to personal history.
Yes, sir.
This should come here. Okay, so you try
Bowel
to
habit.
give a complete history. Don't be biased with peptic ulcer disease.
Yes,
This
yes,
can be something
yes,
else.
yes.
Okay, this can be a CS stomach. So try to give the other symptoms, whether he has got any respiratory disease, whether he has got any metastatic symptoms like spread from carcinoma stomach. So don't get biased that it's a peptic ulcer disease. When you see a patient, try to think the patient in profile and then ask other symptom disease. Take the detail of GI symptoms, take urinary symptoms. You see, this patient is having constant vomiting. So he may be dehydrated.
Yes, he is dehydrated.
He may have a less amount of urine passing.
Yes.
So try to include everything. History of presenting illness is the main area where all history should come. So
Yes,
take the whole
yes.
comprehensive history in the history of presenting illness,
So,
rather
sir,
than going to
I'll
the
include some bowel habits and
bowel habits,
so
respiratory
here
symptoms.
and as well as in the personal history.
No, personal history is not mentioned. If you have mentioned the bowel habit in history of present illness, that is you skip in personal history because it is already a GI case where bowel habit should, suppose is a patient of carcinoma colon. So why do you place the bowel habit? Not in the personal history. It should come in the history of present illness. So make a habit that history of present illness should be containing all the systemic symptoms. It may be negative. He may have no breathlessness, he may have no chest pain, cough, or hemoptysis. So that we will use at the end to say that patient has no other systemic symptoms. Okay, go next.
Okay. So have you mentioned about
Appetite.
any weight loss of the patient?
Yes, appetite, weight loss. These all should come in the
Appetite and weight loss. Yes.
What about weight loss?
So there is history of weight loss.
Yes,
but,
there has to be. Patient, even in a benign disease, will have weight loss. Because he is a patient
Now,
who is vomiting after every feed. Yeah.
In this connection, I would like to ask you, what are the usual causes of acute weight loss in a surgical patient?
So acute weight loss in cases
Different
of
situations when
chronic
the patient, yes,
debilitations of the chronic
Acha,
debilitations where the patient is
so go on.
Listen to the question. Surgical patient
surgical
having
major
rapid weight loss.
So patient undergoing major surgeries and the patients who are on parenteral nutrition.
No. He said, what are the causes of acute weight loss in surgical patient? One is this. Patient having gastric outlet obstruction.
So
maybe
gastric
due to
outlet
critical
obstruction. So patient
He's
may not
vomiting.
be able to take food. Think
Yes.
in that layer. Patient is not able to take food because of some surgical reasons. What are the conditions that can be?
So could be
So that
so could-
esophageal malignancy,
esophageal malignancy,
esophageal stricture, cardiac achalasia. So that might be from the esophagus point of view. From the stomach point of view, it may be gastric outlet obstruction for any reason. Okay.
Yes.
In a post-operative case, it can happen if there is a bowel fistula. If I go on to the pancreas, what can be the reasons? Chronic pancreatitis, or of course, diabetes mellitus. Any other endocrine situations where the patient might have weight loss, significant weight loss, endocrine disorder?
Thyroid.
Yes.
hypothyroidism.
Hyperthyroid.
What is
Thyrotoxicosis.
thyrotoxicosis? So these are the bowel fistulas I have already mentioned. So these are the usual situations where the patient might have an acute weight loss. Now, coming at the picture, seems to be a case of gastric outlet obstruction. So at the history, having this history, I want to know what can be the different causes of gastric outlet obstruction.
So apart from peptic ulcer, sir, it could be sir.
So taking the history of this
benign
patient.
causes, I want to know the benign causes only.
So there may be a stricture of pylorus, sir. Then there may be sir extrinsic.
Start with that the lumen is blocked because of the presence of some foreign bodies. What can be the situations?
So in case of bezoars, sir.
What are phytobezoars and trichobezoars?
So trichobezoars, when the patient ingests hair and
So it's a hairball.
Hairballs.
It's a hairball causing obstruction. It's a trichobezoar. And some vegetable residues which can form a ball and the phytobezoars.
Or any other big foreign body obstructing the pylorus. So trichobezoars, phytobezoars, and a big foreign body, let's say a large coin in a pediatric patient, that can also give rise to gastric outlet obstruction, foreign body within the stomach. Okay. Now coming on to the wall of the gastric outlet. So what are the causes? One is scarring, stricture related to peptic acid peptic disorder. Okay, this is one. What can be the other situations involving the wall?
So there may be carcinoma of the
benign cause, if you say.
No, benign, only benign.
There may be extrinsic compression of the pylorus.
So we'll go to that. First, I mentioned about the causes within the wall. Can it be a tuberculous stricture?
Yes, sir.
So it can be a tuber. And another very not uncommon scenario is ingestion of corrosives. Okay, so acid ingestion. Acid ingestion.
Pylorus stricture is common. Pylorus stricture is common following acid ingestion.
So which type of acid usually gives rise to gastric outlet obstruction? A strong acid or a weak acid?
So weak acids. Alkalis are more
weak acid. Weak acid. Why weak acid?
So they are more corrosive in nature, sir.
It's not that, because weak acid usually does not give rise to any harm to the esophageal mucosa because it quickly passes into the stomach. It remains into the esophagus for only a transient period. It can't do any harm to the esophagus, but it stays a longer time into the stomach. So that's why it can lead to injury to the pyloric mucosa or gastric mucosa as a whole, and can lead to scarring. On the other hand, a strong acid, patient takes a smaller amount, and it can definitely injure the esophageal mucosa rather than the gastric mucosa. So it's not usually hydrochloric acid, but it is usually muriatic acid, which is a weak acid. Now come on to the outside the wall causes. What can be the benign causes? Benign causes.
Yes, sir. Extrinsic compressions due to, sir,
Extrinsic compression. Yes.
lymph node enlargement due to TB, sir, or any other causes
So
malignancies.
erythroperitoneal mass, erythroperitoneal swelling of any etiology, chronic pancreatitis.
Chronic pancreatitis can sometimes present with outer obstruction.
Or a pseudocyst. It can also give rise to obstruction. Okay, then go on. So that's about the history. Dr. Shah, anything else in the history?
Okay. What I'm trying to say is he should also mention the systemic symptom in history of present illness.
Physical examination. General survey. Patient was examined in decubitus position. He was conscious, alert, and cooperative. Vitals were within normal limit. Tongue was dry. Skin turgor is reduced. The patient is moderately built and poorly nourished. BMI of 20.8. Pallor is present. There is no lymphadenopathy, pedal or sacral edema. Performance status, Karnofsky scale 90. On local examination, inspection, abdomen is scaphoid with visible fullness in the upper abdomen. Umbilicus is central and is normally inverted. There is an operative scar, Magburn's incision scar in the right iliac region. Visible peristalsis seen in the upper abdomen, in the left hypochondriac region, epigastrium, and in the right hypochondriac region, moving from left to right direction. Hernial sites are free, and external genitalia are within normal limit. On palpation, there is no local rise of temperature. Abdomen is soft, is not tender. There is no guarding or rigidity, no hepatosplenomegaly. Hernial sites are free. External genitalia is within normal limits. On auscultopercussion, the distended stomach is present in the epigastrium, left hypochondrium, and the right hypochondrium, and the umbilical region with visible peristalsis from left to right. Normal peristaltic sound heard in the rest of the abdomen. There is no shifting dullness. On digital rectal examination, normal anal tone and mucosa, normal stool staining is present. Systemic systems are within normal limit. Summary: Mr. X, 40-year-old male, gentleman, present with a moderate intensity, dull aching pain in the mid upper abdomen for the past 2 years, which was more in empty stomach and was relieved partially with food intake. He complained of heartburn, acid taste in the mouth for the past 2 years. He complains of projectile non-bilious vomiting following food intake for the past 5 months. Vomitus contains food taken 4 to 6 hours earlier. He often experiences a sensation of ball running in the upper abdomen following food intake, which subsides after vomiting. He has a history of occasional binge drinking for the past 10 years and regular smoker for the past 10 years. History of appendectomy 15 years ago. On general survey, the patient is moderately built and he is dehydrated. Pallor is present. Abdomen is scaphoid with fullness in the upper abdomen. Visible peristalsis is seen in the upper abdomen moving from left to right. Magburn's incision scar visible in the right iliac region. Distended stomach in the epigastrium and left and right hypochondrium and umbilical region delineated via auscultopercussion. Other systemic examinations are within normal limit. This is my provisional diagnosis would be that this is a case of a gastric outlet obstruction due to chronic duodenal ulcer.
Okay.
Dr. Shah, start it.
Yeah. You should straightway mention that patient is dehydrated. Okay.
Yes.
Skin turgor is reduced, tongue is dry. So there is evidence of dehydration. And you said moderately built and poorly nourished. You see, if you say BMI is 20.8, this patient is falling within the range of normal nutrition. But how do you assess nutrition in a patient like this? You see, nutrition is not only BMI. There are a lot of other things which should you consider in assessing the nutritional status.
We check for skin thickness, mid-arm circumference.
One is skin fold thickness.
Skin fold
What component of nutrition is assessed by assessing skin fold
So,
thickness?
amount of fat.
Fat. Yes. Then
So
then medium circumference. You see, patient is vomiting for last 5 months. This patient must have some muscle wasting.
Yes.
So you should assess the medium circumference. And what else? What about micronutrient deficiency?
So,
How do you assess micronutrient deficiency? Micronutrients are vitamins.
Vitamin deficiency.
Then
So you might have history of bleeding gums or losses.
vitamin A deficiency may cause night blindness.
B deficiency.
Patient may have dry
Dry
eyes. Patient may have glossitis. Patient may have angular stomatitis.
Yes.
Okay, so you should also look for this. So nutrition is not only the BMI.
Just
So you should have global assessment nutrition. You say performance status is 90. When do you say 90 is performance
So
status?
patient can do all this activity on his own without.
And patient has minor symptoms and signs of the disease. What do you think in this patient? Are these minor symptoms? These are major symptoms. You see, patient is vomiting after every feed. He is malnourished, he is dehydrated. How can he do normal activities? It's unlikely.
He can do his daily activities on
You
his own
see,
without any help.
If somebody is vomiting after every feed, he is malnourished, he is dehydrated, it is very unlikely. Like to assess, when you are commenting something from performance status, you should be very clear about it. 90 is impossible. This patient has major symptoms and signs of the disease. Even if he can do his normal activities, it should be at least 80. It's not 90. Okay. And then what about other examinations? You say no lymphadenopathy. Okay. Next abdominal examination. Yeah. You see, once you say there is visible fullness in the upper abdomen, then abdomen cannot be scaphoid.
So, but just
Scaphoid means what?
Scaphoid means
from the xiphoid to the symphysis pubis, there is a bowing inward. If there is a fullness in the epigastrium with the visible pressure, how can it be scaphoid?
So there is fullness in the upper abdomen.
So the scaphoid is out. If the abdomen is full in the upper abdomen, it cannot be scaphoid. Okay, so you should mention this fullness.
Okay.
Operative scar. Then what about the respiratory movement?
The normal respiratory.
So you see, make a legible description of your inspectory finding in the abdomen. Okay, fine. Next, palpation. What you have tried to appreciate in this patient? You said patient has got an outer obstruction. You said abdomen is non-tender. Where you look for tenderness in this patient?
So I examine all the.
You have examined all the tender spots. Have you examined for the Magmanis tender spot? Why?
For general examination, sir.
It's not necessary. Patient does not have features of acute appendicitis. Why do you look for Magmanis point tenderness? Here, the tenderness importance is either a duodenal point tenderness or epigastric tenderness.
What are these points?
Where is the duodenal point?
So it's in the transpyloric plane, 2.5 centimeters
from the
midline.
Right of midline. Right. Yes. So you should look for those points, whether he has got any tenderness in this. No guarding, no hepatosplenomegaly. And when you palpate, you have described that you can see the visible peristalsis. So have you felt any lump in the abdomen?
So not.
There is a classic description. If you have a distended stomach showing visible peristalsis, in that case, if you put your hand in the abdomen, you can feel the distended stomach. But it is not a solid mass which is under your finger. In that case, you can feel the distended stomach which disappears under the palpating finger. So that is often a feeling. And then on palpation also, when you go for the examination for percussion also you should do. On percussion, the distended stomach will be resonant. And rest of the abdomen will be resonant. Exclude, there is no free flow in the abdomen. Auscultative percussion is not no shifting dullness. That is not with the auscultative percussion. Auscultative is a different examination. So you should make a heading of percussion. And then you look for succussion splash. How do you demonstrate succussion splash?
So we put the stethoscope in the
See that patient has not taken food within 3 hours.
Three hours.
Okay, patient should not take drink or food for three hours. So place the stethoscope in the epigastrium and try to gently shake the patient. You may hear audible sounds. And then how do you do auscultative percussion?
So we put the stethoscope in the epigastrium and then we use a pencil the back of the
and
pencil
scratch from the left costal margin downward. You said that you find that greater curvature is below the umbilicus, suggesting the distended stomach. Fine. Why do you say this is a case of gastric outlet obstruction? What make you feel that patient is outlet obstruction?
So because and
okay, Doctor, what's any question on the examination?
Okay. Have you done the rectal examination?
Yes, he has mentioned.
Yes.
What is the importance of doing the rectal examination?
So the patient can also have such symptoms in intestinal obstruction, sir. So on rectal examination, we might find some ballooning or
patient having symptom for last 5 months cannot be acute intestinal obstruction. Don't bring a wild differential diagnosis.
Yes.
He's having symptom for last 5 months.
Abdomen. It's a chronic abdomen. And what is the importance of doing the rectal examination? So the etiology might be malignant as well. If it is, if the etiology is thought to be a malignant one, what is the utility of doing the rectal examination?
So to look for any, if there is a.
Or in this connection, I would like to ask you, what is Bloomer's shelf?
If you do a rectal examination, and when do you say, yes, there is a presence of Bloomer's shelf? What do you feel on putting your finger in the rectum? Bloomer's shelf.
Have you heard?
There is Bloomer's shelf. Bloomer's shelf is a pelvic metastatic deposit. So if in a male patient you have a pelvic deposit, there means some deposit between the bladder and the rectal mucosa. So you put your finger on the anterectal wall, you'll find there is a bulge inside the rectal lumen, which is formed film.
Yes.
And second one, whenever you are taking out your finger, you will have to find whether that is a Melina's stool as well or not, in acute situations particularly. Yes. Now, in this connection, I would like to have one more question. If it is a Melina's, what are the usual characteristics of Melina's stool?
You have your finger is smeared with black stool. What are the characteristics of this? Say that is
Melina's stool.
So it's black, sir.
Black, sticky, and
sticks to the
and foul smell.
And if you wash your finger, what will be the color?
Red stains.
So, what is the complete description of a Melina's stool? Complete description of a Melina's stool.
So it is black, sticky, foul-smelling, and when we wash it or it's mixed with water, so there is reddish discoloration because
and two more adjectives, sir. It is frequent and it is semi-solid. Okay, so done. So after that, you have reached your provisional diagnosis. What is the provisional diagnosis?
So my provisional diagnosis, it's a case of chronic duodenal ulcer.
And
chronic duodenal. So chronic duodenal ulcer
with gastric outlet.
With gastric obstruction. Okay. Why do you say patient has outlet obstruction?
So because the patient started with a history of vomiting for the past 5 months, with the frequency has increased, and he had first he had he was having difficulty in eating solid foods, and then slowly, he was also having discomfort and vomiting on taking liquids. So I would say it's a case of
The vomiting is projectile in nature.
projectile in nature. Yes.
And this vomiting occurring after every feed.
Every feeds.
Okay. And why do you say this vomiting, this outlet obstruction is likely to be a complication of peptic ulcer disease?
So because of the history, sir, because the patient gave a history of acid reflux, to his past history of acid reflux from the past 2 years, and also the pain is dull aching in nature. And
What is the classic pain of peptic ulcer disease? Includes chronic gastric ulcer and chronic duodenal ulcer.
yes,
Okay.
yes,
So these two are different.
yes.
So this patient you said chronic duodenal ulcer.
So the pain.
What are the characteristics of pain in a patient who
Related
has
to
got
chronic duodenal ulcer.
So
Okay.
in duodenal ulcers, there is pain on empty stomach, sir, and the pain subsides after taking meals or taking antacids. And in gastric ulcers,
No, wait, there are some more features. The site of pain in chronic duodenal ulcer is in the
duodenal points.
is not in the duodenal pain, is the epigastrium.
Epigastrium. What is the
And-
nature of the pain?
Yes.
So
And what is the intensity of pain? How does it start? How does it come down? Etc. All these pains, points
Yeah.
related to pain.
It's
One by
dull
one, you
aching in
tell us.
nature, sir. It starts when the patient is in empty stomach,
Yes.
and
Dull aching and more
dull aching.
often described as a burning character.
burning sensation.
And one of the more important character of this peptic ulcer disease pain is these pain are usually periodic.
Yes.
If you go to the history of this patient for 2 years, you would have found that it may not be a continuous pain. There the
Seasonal.
patient has got
Seasonal.
pain, which is there for about 2 to 3, 4 months, and then pain disappears because of spontaneous healing of the ulcer. And then after a very short period of time, patient has relapsed of the same pain. So this is the pain which has got in duodenal ulcer disease. The periodicity pain is more marked than gastric ulcer. Gastric ulcer patient may also have periodicity, but periodicity is more predominant, more marked in chronic duodenal ulcer patient. And this patient may have features of hyperacidity in the form of heartburn, eructation of sour fluid in the mouth.
And
Okay.
how does the pain of gastric ulcer differ from duodenal ulcer, and how does the pain of gastric carcinoma differ from duodenal ulcer pain?
The pain of gastric ulcers is relieved after vomiting, sir. Sir,
After vomiting often occurs after taking of meals.
taking of meals.
And the periodicity is less marked.
Periodicity is less marked.
And the other patient of gastric ulcer who has more history of weight loss.
Yes, sir.
Duodenal ulcer patient does not have periodicity unless patient has outward obstruction. Rather, the duodenal ulcer patients have gain weight because they frequently take food.
Take meals.
Okay, but once the outward obstruction occurs, patient will have weight loss because of constant vomiting.
And what about the pain of gastric carcinoma?
So,
Does the
this
patients
was-
of gastric carcinoma suffer also from pain?
yes, sir, chronic dull pain, sir.
What?
So
You
no,
see, the classic history will be different. A
There is history of
patient
pain.
having carcinoma stomach will not have a history of long duration of 2 years or 3 or 4 years. Short duration.
Short duration pains.
And again, this pain is what is the difference with the pain between the peptic ulcer disease?
So this pain is not related with the there's a
Yes.
constant pain. This is not related.
Yes.
Really not
Yes,
related to
yes. So it is non-remitting pain, persistent pain, low intensity pain. Rather, unlike the gastric ulcer or unlike the duodenal ulcer, persistent pain, but it is of low intensity pain. In duodenal ulcer, it is often a sharp intensity pain. So persistent, low intensity, dull aching pain that is not related to food at all. That is basically the pain might be due to a gastric carcinoma. Okay. So
Any
that is the
differential
clinic.
diagnosis? Any differential
Yes.
diagnosis in this patient?
So
Because I find in the history, there is another predominant history of alcohol intake for long duration for 10 years. He is a smoker. So any differential diagnosis?
Pancreatitis.
What
Chronic,
pancreatitis?
chronic,
What
Yes.
type of pancreatitis?
chronic pancreatitis.
Chronic pancreatitis. Yes. This is a patient with a long history of alcohol intake. Often you have to then specifically ask about the character of the pain.
Correct.
In chronic pancreatitis, the pain character is, what is the radiation of pain in
the
chronic
pain-
pancreatitis?
Because the pain radiates from the radiates towards the back, sir.
Yes.
And
And what are the other features? In a patient who has got a chronic pancreatitis, we classically say that patient can present with triad. What is the triad of presentation of patient having chronic pancreatitis?
So,
So one is
pain,
deep boring pain that you have already mentioned,
Pain.
radiating
One is
to back.
pain.
So this
What
is
else
one.
in the triad of chronic pancreatitis? Pain.
relieved on bone,
Then the pain is one. What else?
diabetes.
Yes. Endocrine deficiency.
So
Diabetes,
that is
and
endocrine
third is-
insufficiency. Can there be
and third is
exocrine insufficiency
exocrine
as well?
insufficiency manifested as
State.
steatorrhea.
Exo
So if the
steatorrhea. So
patient
this
has
is,
got this, so these are the things he should also find out in the history part.
Yes.
Whether he has got any recent onset of diabetes, whether he has got any steatorrhea. So these are the pointers towards diagnosis of chronic pancreatitis.
so
Because
can the
alcohol
patient
intake
of du
Yeah.
can the patient of duodenal ulcer may also have a deep boring pain radiating to the back?
Yes.
When?
When
So when there is a
If you go to the ulcer complication, there is one
posterior
complication of the
duodenal
ulcer
ulcers.
which can cause pain being radiated to the back.
so when the ulcer involves the
That is described as ulcer penetration, not perforation. If it's perforation, it will be a generalized peritonitis. If there is a slow penetration of the ulcer in the posterior side, it will not be free perforation. In that case, patient may have pain which can radiate to the back, like chronic pancreatitis. Okay. So you say
can
there
we-
is no contact of
yes.
tuberculosis, there is no fever, everything should come in this representation.
Yes, yes.
Because we had a DD of tuberculosis. Tuberculosis is a universal disease, can occur anywhere. So you should also exclude any history of pulmonary tuberculosis, any history of fever, whatever. Okay. So with this diagnosis, how do you like to approach this patient?
Yes.
So, so I would like to, sir, first go for, sir, for investigations. I would like to go for upper GI endoscopy, sir.
Again, make a heading. The investigation to
Yes.
confirm the
Confirm
diagnosis.
the diagnosis.
Investigation to
Establishing
assess
your
his
clinical
fitness for
diagnosis.
anesthesia surgery.
Yes.
So for assessing the fitness, we have
Make
to,
first confirmation of diagnosis.
So, I
Establishing
would like
your
to-
clinical diagnosis.
Yeah.
so I would
Yes.
like to go for upper GI endoscopy.
Yes. So the first investigation should be a upper endoscopy. This patient having outer obstruction,
Yes.
can you straightway send this patient for upper endoscopy to the endoscopy next morning?
No, sir, we have to prepare the bowel, sir. First, sir.
Not bowel, the stomach.
Stomach.
So patient having outer obstruction often may have difficulty in doing endoscopic examination because of food residue in the stomach.
Yes.
So to have a proper examination, he may be dehydrated.
Yes, sir. So we have to
So,
resuscitate the patient.
So you have to optimize the patient
Optimize the
for
patient.
undertaking this investigation.
Investigation. Yes, sir.
So it will be correction of his
Correction of
dehydration.
his dehydration.
Then,
he's
How do you correct his food residue?
so gastric lavage, sir.
Gastric
We have the
lavage.
gastric lavage. The
Yeah.
patient has pallor, sir. We would correct his anemic status. And
Okay. What do you like to see in endoscopy?
So, yes.
What are the classic feature in endoscopy in a patient who has got outer obstruction due to chronic duodenal ulcer?
so with good bowel preparation, there is still some food residue, sometimes food residues in the
That depends on your preparation. Fine. What do you find? You find there is a hugely distended
distended
stomach.
stomach, sir. And
What is the difference in distension of the stomach in a carcinoma versus peptic ulcer disease?
so
Is there any difference in the distension?
so loss of glucose?
So that is regarding distension of the stomach. Firstly,
What do you
one is
expect?
of shorter duration, one is of longer duration.
And in carcinoma stomach, there may be infiltration of the wall by malignant cells.
Yes, sir.
Consider
And
line
the stage duration is short. So in a benign disease, you will find more distended stomach than in malignancy. And Chintamani has got a very favorite question. You said projectile vomiting.
Yes.
What is the vomiting in malignancy? Why there is projectile vomiting?
So because there is a reverse peristalsis due to
That means there is
stomach.
pyloric obstruction.
Yes.
And stomach is trying to contract and push the food to the duodenum.
Yes.
Instead of passing to the duodenum, it refluxes.
Yes.
So stomach is violently contracting.
Yes.
But in CS stomach, there may be infiltration of the stomach wall with malignancy. So in that case, the violent contraction may not be so predominant in a benign disease, in a malignant disease. So it can be effortless vomiting in a malignancy. It may not be always a projectile vomiting. Okay, that is his favorite question. Okay, so this essentially more in benign disease.
Yes.
So once you go in, you find a huge distended stomach. Okay, the rugosity may be there. In a classic peptic ulcer disease, the rugosity may not be effaced. Okay, and what about the pyloric area?
So it is pyloric area is constricted and the probe cannot.
Yes, often it can happen that the endoscopy may not pass the endoscope beyond the pylorus because of the
because of the obstruction.
And usually the stricture is not in the pylorus. It's in the first part of duodenum. It can go to the pylorus and then beyond the duodenal stenosis, the scope may not go. And what about presence of active ulcer in a patient who has got outer obstruction?
Presence of
active ulcer.
So
Active
what will
ulcer
be the
is
appearance
not
of active gastric ulcer or active duodenal ulcer? What will be the
most of the
appearance of
cases, in most of the cases, you will not find the active ulcer. This outer obstruction is because of scarring. So you may not find an active ulcer in most of the patients. It's only healed, scarred first part of duodenum. Okay, so if it's a duodenal stenosis, there is no question taking biopsy. Okay, so this gives a diagnosis of benign versus malignant disease.
Now, coming on to there, if you find out a gastric ulcer, yes, present on endoscopy, you can find out a gastric ulcer. How will you differentiate between a benign gastric ulcer and malignant gastric ulcer endoscopically?
What are the characteristics of a benign ulcer versus a malignant ulcer?
Sir, so benign gastric ulcer, sir, the margins would be more rounded, sir, and
benign will not be rounded. Benign will be punched out. Rounded, raised margin will be in case of malignancy.
Rounded.
And if you see the gastric rugosity,
the size and location, what will be regarding the size and regarding the location of ulcers? Now, in this connection, can you tell me what can be the different locations of gastric ulcer?
Yes, sir.
Do you have any classification regard to that?
Yes, sir. So type 1 gastric ulcers are present.
What is the classification known as? What is the classification known as? Johnson's classification.
Johnson's classification. So in type 1, sir, the ulcers are present along the lesser curvature. Type 2, sir, are present in the duodenum. Type 3 are present in the pre-pyloric area. Type 4 are present along the upper part of the lesser curvature.
Again, go on again. So type 1 is on the lesser curvature close to the incisura. Okay, not high
yes,
up.
Sir, close to this.
Okay.
Yes, sir.
This is
type
one.
2.
And what about the type 2 and type 3?
Types 2, sir, in the duodenum, sir. Type
duodenum.
3 in the
only in duodenum.
Both
duodenum and the
combined ulcer.
Combined ulcer.
So it's a combined ulcer. And what about the type 3 ulcer? It's only a pre-pyloric ulcer.
Yes, sir.
And what about the type 4 ulcer?
So in the upper part of the lesser curvature.
So high up in the lesser curvature. And what about the type 5 ulcer?
So they anywhere along the body, sir.
So anywhere
Body
in the body might be related to stress ulcerations or something like that, or
Stress
NSAID induced.
NSAID induced ulcers.
So and what can be the radiological finding in the case of gastric outlet obstruction?
So
Air contrast barium meal.
so there may be, sir, we can see the retention of the contrast in the stomach, and
First of all, is distended.
we see the
First, distended stomach.
distended stomach.
Yes.
We see distended stomach, and after taking a late exposure after 4 to 5 hours, we can still see the presence of dye in the stomach. Or if the dye is present in the stomach as well as in the colon, sir, we can also see that, sir. Showing us that there is a retention of dye.
That means like a delayed film.
Delayed film, yes.
The contrast will be remaining in the stomach.
Yes.
Okay. And what are the other investigations? So one is endoscopic. You will like to assess the endoscopic picture, and you would like to assess the along with the radiological picture if you want to supplement it. And what are the other investigations would you do?
So we can also do, sir.
The patient of peptic ulcer disease causing obstruction. Will we use US? Right?
To assess the depth if the ulcers.
No. You see, it all depends on your endoscopic finding. Your history suggestive of a chronic renal ulcer causing obstruction. US is costing you 15,000-20,000 rupees. Why do you ask for an investing which will not contribute to your management? US, you can think of in a situation has got a suspicion of malignancy. In a benign disease, there is no role for doing a US in this patient. No, not at all.
So then I would like to go for some routine investigations to see for the deselectivity.
Some are not routine here. Some are more important here. This is a patient who is having vomiting after every feed.
Yes, sir.
So this patient will have some biochemical abnormalities.
Yes.
What biochemical abnormalities you expect in a patient who has got outlet obstruction?
So because of the routine vomitus, sir, there is a hypochloremia and metabolic alkalosis, followed which there is.
Don't stop only with hypochloremia. These are the patient who is having vomiting for last 5 months. Every feed for 1 month. Yes. What is the full blown picture?
Yes, sir. Hypochloremia, hypokalemia, metabolic.
What about the sodium? What about the sodium?
Hyponatremia. These patients also have hyponatremia.
Yes, sir. So, but it's compensated with.
No, it's not compensated. In a full blown situation, these are the patient who has got hypochloremic, hypokalemic, hyponatremic, metabolic alkalosis with paroxysmal. These are end stage. If you have a situation which is the beginning of vomiting, patient may not have hyponatremia at the beginning. Hyponatremia comes in the later period. Why there is paroxysmal aciduria in a patient who has got a metabolic alkalosis in the background of outlet obstruction?
So because first
you have to explain that paroxysmal aciduria.
Yes, sir. So first, because of metabolic alkalosis, there is excretion of bicarbonate to compensate for the metabolic alkalosis. After a while, along with that bicarbonate, there is loss of sodium.
Yes. So at the initial phase, when patient has got metabolic alkalosis, body try to compensate by excreting bicarbonate, and while doing so, there is loss of sodium with that.
Yes, sir.
So what happens afterwards?
So afterwards, there is hyponatremia. There is activation of the
sodium cannot be excreted. Yes, go on.
Yes, sodium is not aldosterone is.
So there is aldosterone response. Body tries to conserve sodium because sodium is a very important ion for metabolic function of the cell. So body now tries to conserve sodium.
Yes.
by aldosterone response.
Yes, sir. There is
So how is the sodium retained?
So there is retention of sodium from the distal convoluted tubules by exchange of H plus ions and potassium
H
ions.
ions.
That's
So
why
that
on
gives
the
rise to
background of
paradoxical.
alkalosis, patient has
Paradoxical acidity.
Now,
Fine.
can I ask you one thing? Suppose the patient is not having gastric outlet obstruction, patient is giving simple history of peptic ulcer disease. Would you like to suggest upper GI endoscopy as soon as the patient comes with symptoms suggestive of peptic ulcer disease?
What is the recommendation?
So we give a trial of medical management first, sir. And if the patient responds, it's good. But if the
So
patient
when would you
doesn't,
proceed for the upper GI endoscopy?
when the patient is still symptomatic after the medical management, so after 4 to 6 weeks of medical management.
Do you know what are the alarm symptoms
So
for upper GI requiring upper GI endoscopy?
So if there is hematemesis, and
Alarm symptoms. So pain plus
Pain.
something other. So when the patient has a persistent dyspepsia, prolonged persistent dyspepsia, and the patient's age is more than 55 or 60 years, and the patient has anemia, patient might have dysphagia as well, patient might have vomiting, persistent recurrent vomiting, as is this case in this situation, and family history of gastric carcinoma. If you are getting a history of family history of gastric carcinoma, so all these are known as the alarm symptoms, where when a patient comes with symptoms suggestive of peptic ulcer disease plus these additional symptoms which are known as the alarm symptoms, definitely you have to proceed for an upper GI endoscopy. Otherwise, simply peptic ulcer symptoms related to peptic ulcer disease, give PPI and judge this situation. If the symptoms persist, yes, intractable situations, you might have to proceed for endoscopy. So these are the alarm symptoms. Okay.
The recommendation is because you have huge number of patients who may have some similar symptoms. So you may not have the facility for doing endoscopy for all. That's why the recommendation is you give the patient initially treatment for peptic ulcer disease unless the point Dr. Bhattacharya mentioned that patient has some other alarm symptoms where you might be missing a diagnosis of malignancy. In that case, you should ask for an early endoscopy. Okay. This is a patient whom we are managing now. We have done an endoscopy and it is showing a benign disease causing outlet obstruction. What should be your plan for treatment in this patient?
So I would like to go for medical management, surgical management, sir. I would like to go for truncal vagotomy.
So keep in mind that patient who has developed a complication in the form of outlet obstruction, they are the patient who needs surgery. Okay, if the patient has got only peptic ulcer disease without outlet obstruction, the primary treatment is now medical management. But patient outlet obstruction, this is the patient who is candidate for surgery. What surgery will plan for this patient?
So I would like to go for truncal vagotomy with gastrojejunostomy.
You need to do a truncal vagotomy.
Yes.
What is the rationality for this treatment?
So because duodenal ulcers mainly occur due to more acid and because of excess of acids. So I would like to go for truncal vagotomy so that the parietal cells denervated and there's the acid secretion and future relapse of the.
Yes. You see, this patient does not have an active ulcer disease at the moment.
Yes.
But as I said that this is a disease which is characterized by relapse and remissions. So unless you take care of the hyperacidity, the other patient who have a relapse of this peptic ulcer. So you need to do some procedure to cut down the acid secretion.
Yes.
You say do truncal vagotomy. What do you mean by truncal vagotomy?
So we ligate the anterior and the posterior.
You ligate? This is the operation you do. You say truncal vagotomy. Vagotomy is not ligation.
So we
You take a
Yeah.
section of the
Take a
anterior
section
vagus
of
as
the-
well as
yes,
the
sir.
So
posterior
you divide.
vagus.
With the
You divide the vagus nerve and you ligate that cut ends.
curtains, ligate the curtains and divide.
Yes, and also you take a segment of nerve to have a histopathological examination.
Now,
What
in
nerves
this
you divide?
yes,
So,
In the abdomen, what nerves you divide?
sir, anterior and posterior vagal trunks.
Okay. In thorax, it is not anterior and posterior. It is left and right. So which one is anterior, which one is posterior?
Sir, the so the left one is anterior and
there
then
is
become
one
anterior.
mnemonic in this regard, LARP. Remember LARP, LARP. So left anterior, right posterior.
right posterior.
Okay, you say truncal vagotomy.
Hmm.
So while doing truncal vagotomy, where exactly you divide the vagus nerve? In abdomen, you can do either it by laparoscopically or do by open surgery. So when you say I'll do truncal vagotomy, why do you divide the nerve? At what area in the stomach esophagus relation you divide the nerve?
So near the entry of esophagus, esophageal hiatus, where the
Yes.
esophageal, where near the esophageal hiatus, where the esophagus enters. The
So
stomach.
as the vagus nerve enters in the abdomen, it gives up two main branches. Anterior gives one main branch and posterior gives one main branch.
Celiac and hepatic branches.
Yes. The anterior gives up the celiac branches and posterior gives the hepatic branches.
Yes.
So if you divide the trunk of the nerve above these branches, you do a truncal vagotomy. What are the other types of
Why-
vagotomy you can?
Yes.
Truncal vagotomy also denervates the whole GIT. If you do truncal
Now,
vagotomy, you
in this
denervate the whole
connection,
GIT. Yeah.
in this
Yes.
connection, can you mention about the criminal nerve of Gracie? What is that?
So it is a division from the posterior vagal trunk, and it supplies the fundus of the stomach. Sir.
So sometimes if you do not take a section of the vagus nerve, that nerve might be missed. Okay.
Yes.
So that's the importance. Okay.
So criminal
it is
nerve Gracie is a branch which is coming little higher up from the main trunk and goes to the fundus. So while dividing, you should divide the nerve as high as possible. Okay.
And
What are the
now
other
coming
types
on
of
to the
vagotomy?
other options. Yes.
Sir, highly selective vagotomy.
What is that?
So we
What is there are another term is called as selective vagotomy. It is
Selective.
difficult to do. You can difficult to identify this main branches. But the another surgery which is applicable for this sort of patient is a highly selective vagotomy.
Yes,
What
sir.
is that?
So nerve of we ligate and dissect the nerve of Latarjet, sir.
You like it, the Latarjet that you preserve. Don't
Oh,
confuse.
sir, 7 centimeter
branches
from your
coming
Preserve the
from
nerve of
nerves of
Latarjet.
later.
we
So highly selective vagotomy is dividing the nerve branches which supply the fundus and body of the stomach. And you stop at the antral region.
Antral region, yes. 7 centimeter.
Roughly 7 centimeter the pylorus.
Yes.
So
Preserving the
what is crow's foot?
So crow's foot are the branches from the nerves of Latarjet which supplies the
So
pylorus.
as you trace the nerve, the anterior nerve and posterior nerve both runs along the lesser curvature. And they give some branches which runs with small vessels toward the lesser curvature of the stomach. So you divide all these branches which goes from the main trunk to the fundus and the body of the stomach and stop short at the antral region, which is 7 centimeter from the pylorus. That is the nerve of Latarjet, and that nerve of Latarjet supply the pyloric antral region, which is the main pump of the stomach. So the idea was, if you do highly selective vagotomy, you can avoid doing a drainage procedure. Okay, but patient having outer obstruction, then this does not come. A patient having outer obstruction, you have to do a drainage procedure.
Yes.
And what is the moment in favor of doing or not doing a highly selective vagotomy?
So
people who are propen to highly selective vagotomy, they are point to us.
So it preserves the motility of the
Motor is the
perceived
stomach and the GIT.
This
You
distal
do
bowel.
not innervate
Okay.
the whole GIT. Yes. It is said that the incidence of gallstone formation is higher if you do a truncal
truncal
vagotomy.
vagotomy. Yes.
Okay.
Yes.
But the point was, if you go to these previous studies, you will find that the incidence of recurrent ulceration was little more in patient who underwent aniseal vagotomy.
Yes, sir. Because
Because it may not be always precise in denervating the exactly the whole of vagus nerve living behind the nerve of lateral jet. So the incidence of recurrent peptic ulceration was little higher in patients who got aniseal vagotomy. You said you'll take gastrojejunostomy.
Yes.
What gastrojejunostomy will do? There are different types of gastrojejunostomy.
So I would like to take a roux limb from jejunum and gastrojejunostomy and
Yes, that is a better way of doing gastrojejunostomy nowadays. What is the advantage of doing a roux and Y gastrojejunostomy vis-a-vis a loop gastrojejunostomy?
So in loop gastrojejunostomy, so there is more chance of bile reflux.
Yes.
That's why.
So if you do a loop gastrostomy, earlier the description was you do a posterior short loop isoperistaltic gastrojejunostomy. That was the classic description of doing a gastrojejunostomy. Is a posterior short loop
Retrocolic.
Isoperistaltic gastrojejunostomy. That is a classic description. But now there are a lot of reports saying that there is a higher incidence of bile reflux gastritis if you do loop gastrojejunostomy. So the better option is to do a roux and Y. But again, with bariatric, people are doing only loop gastrojejunostomy.
Yes,
If
you
you
do.
bariatric procedure, if you do a small pouch of stomach and then they are doing only loop gas, I asked a bariatric surgeon, they say nothing happens. But there is still a possibility of bile reflux, even with a bariatric procedure. But again, the study has to go for a long period. But they are all doing, now some people are also doing roux and Y.
What can be the complications of a roux and Y anastomosis? Do you know what is roux loop syndrome?
So dumping syndrome, sir.
No, roux loop syndrome. Doctor.
No.
Awesome.
So this segment becomes having a less function in comparison to a functioning limb. So that may not have a proper peristalsis, giving rise to stasis of food in the stomach. So there can be something like dumping syndrome as well in this situation. This is classically known as the roux loop syndrome. And what can be the other complications out of loop gastrojejunostomy, post-operative complications out of it?
So there might be recurrence of ulcers in
First,
the
before recurrence, you see, the complication means you start with everything. Early complications. There may be stomal
obstruction due to edema. Sir.
Okay.
There might be stomal obstruction, sir. There might be recurrence of ulcer in the jejunal.
No. There are two loops. One is going up and one is going down. Afferent loop and efferent loop. What
Yes,
can
sir.
happen to the afferent loop or the efferent loop?
So there might be some stasis in the afferent loop for which would cause food stasis. And
Can it be prevented during
yes,
operation by doing something else?
so it can be given.
Earlier, people used to do a jejunostomy. If you have a long afferent loop, you can do a jejunostomy. So that
if it was a long afferent loop,
Yeah.
Okay.
Okay, it's 9:10. I will conclude.
Okay.
Thank you, Dr. Bharti.
Thank you very much.
Thank you, sir.
तुमको तो शौक को बोलना था पेशेंट